Here we go. Good morning. I can hear myself now. Welcome, everybody. Thank you for coming to lovely Seattle and on a lovely day. And we have an extremely full agenda today. It's going to involve some choreography, moving around, working in groups, and it's very timely. The meetings that we've had up to this point are really building up to the work that we start today. And while we're doing that, the ACHs in the 9 districts around the state are in various stages of developing their own models for funds flow. And certainly payment is being discussed in lively ways in the provider groups. And so our work and how we connect with the ACHs and where they are in their work is very timely. And today will help us, I think, get very focused and organized around that. So we have a lot of help in doing that work. Before I make any sort of introductory comments, before we get started into the agenda, why don't we take care of any administrative issues around phones, people calling in on the line. Stella?
Good morning, everyone. So for the folks on the webinar, you are muted, and if you have any questions, please send them through the questions pane on your toolbar on your right-hand side. And for those in the room, please speak through the microphones. You'll see a little button with a mouth on it, and that's the button that you'll need to click to activate your mic. When you are done speaking, please turn off your mic. And just to be aware, 5 mics can be on at a time. So if you are having trouble activating your mic, it is probably because you're the 6th mic. So just please let us know, and we'll make sure to get you on the microphone. Thank you.
Any questions about that? So that we can propel ourselves right into the agenda, let me just make a couple of comments to frame what's going to be happening over the next 3 hours. What we are taking on in Washington is ambitious and complex and the right thing to do. And this group here is going to be informing the way forward in a very real way for the HCA and for all of the providers across the state who are working with the Medicaid population. Don't have to review the headlines, but certainly the noise in the background is distracting nationally, yet we are very focused in this state on what we want to do with the expanded population that we've been serving in Medicaid and being able to sustain that for the next long time. In order to do that, we have multiple points of view that need to be considered, blended, worked together, choreographed, so that everybody's reason for being is sustainable. We're all running businesses, however small or large, and there is a way to put this puzzle together, and that's our work. That's the kind of discussion we're going to be having today. We do have some input that will probably begin emerging today in the discussion from some of the ACHs, which is really healthy, so that we move forward in a coordinated way. This is frustrating because a rational person would say, well, we're making this much more difficult than it really is. What you have to do is have a single payer system. This is not a benefit. This is a blah, 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 you know, the stuff around covering a population for population health purposes. Human beings are the natural resource of the country, right? Well, that's the easy stuff. The hard part is that's not reality. And we have a fee-for-service system that we've been hooked on for a long time, and we're migrating away from that. In order to do that, there are millions of moving parts. We need to get that worked out. So that's our business, and what we are talking about today is building a way forward over the next 5 years or so. That's progressive. It isn't going to happen all at once, and we are trying to minimize the unintended consequences along the way. That's really a major effort. So your thoughtfulness, your input from your respective seat in the industry is extremely valuable in order to build this new picture of a way forward. That's all I'm going to say about framing. The rest is going to come from you, and we have a process to do that.
Thanks, Rick. We have an ambitious agenda, as Rick mentioned. Before we jump into that, I'll just ask for introductions. Rick introduced himself. I'm Mark Province with Healthcare Authority. And JD, why don't you start?
JD Fisher, also with the Healthcare Authority.
Emily Transu with the Healthcare Authority. Rachel Quinn, Healthcare Authority.
Laura Kate Zeichkin, Healthcare Authority.
Alan Fisher, United Healthcare.
Dawn Bonder, Southwest ACH.
Mike Dudas, Virginia Mason, and I'm sitting here with a lens of the small pediatric practices across the state as a representative of the Washington chapter of the American Academy of Pediatrics.
Terry Card with Greater Lakes Mental Health Care in Pierce County.
Kyle Davidson with the North Sound ACH.
Catherine Weiss with the Healthcare Authority.
Jason Aker with the Healthcare Authority.
Caitlin Safford with AmeriGroup.
I'm Rick Ludwig with Providence Accountable Care Services.
Laura Lee, Molina Healthcare.
Francie Chalmers, Skagit Pediatrics, and also representing Washington Chapter AAP, small practices.
Tammy Moore, I'm with Summit Pacific Medical Center, also representing the Cascade Pacific Action Alliance.
Joe, CEO, Kitsap Mental Health. Paul Gable, Coordinated Care.
Sarah Klaus with the Healthcare Authority.
I am Brad Finnegan, a consultant working with the Healthcare Authority.
Kaylee Klein with the Healthcare Authority.
Hi, I'm Joseph Ray with Manat.
Haley Davis with Manat.
I'm Nick Taylor, CFO at Pierce County County State Medical Association. So thanks, everyone. Welcome to this meeting of the UN Security Council. For those of you on the phone, you have to. This is a great visual. It's just an impressive room. So the agenda is up on the screen. I'm going to advance. The meeting objectives are on your agenda as well. So I don't need to read through them, but please keep these in mind as we go through the morning, and I think they're reflective of the introductory comments that Rick made as well. I did want to just remind the group of the charge for the MVP Action Team, and I think it's particularly pertinent today because we are really looking to provide guidance, recommendations, advice, direction that ACHs can find helpful as they look to incorporate value-based payment strategies, approaches, needs, and resources into their project plans. So just if you'll forgive me, I'm going to quickly read through this. The MVP Action Team will serve as a learning collaborative to support accountable communities of health and Medicaid managed care organizations in attainment of Medicaid VBP targets. It will serve as a forum to help prepare providers for value-based contract arrangements and to provide guidance on HCA's VBP definition based on the HCP land framework. And we'll try not to throw too many more acronyms into the discussion, although I suspect we'll all do that over the course of the morning. Updates since the last meeting. I'm going to ask JD to take us through this.
Ask somebody. All right, thanks, Mark. So I just wanted to take a few minutes to update the group about where we are with our various value-based purchasing paying for value surveys, starting with just a general overview of kind of level setting for the purpose of these surveys. So the survey we're doing this year is really the third iteration of this type of work. We started in 2014 with a joint request for information with King County, where we asked for information from plans and providers about their respective value-based purchasing activities and care transformation activities. We followed that up last year with our first less formal survey of value-based purchasing to plans and providers, and we plan to do that annually moving forward. Most importantly, and what kind of began this work is so that we can track progress towards meeting our paying for value goals, which again are 90% of state financed and 50% of the commercial market to be in value-based arrangements by 2021. We're also looking to expand this year to gather additional information, particularly from the managed care organizations for other purposes relative to the Medicaid transformation demonstration and regarding the new MCO contracts. And we're also hoping to get a little bit different and more qualitative information from providers to inform some of the accountable communities of health activities relative to the project planning development process. So next slide, please. I just want to walk through each of these surveys one by one to give you an update of where they currently stand and just a brief overview of the purpose. So the MCO survey is, twofold purposes: to track progress towards our state finance purchasing goals, but also to establish baseline VBP arrangement measures for the Medicaid transformation demonstration and for the 1% withhold in the MCO contracts. This year we're asking MCOs, or we asked MCOs to report on a regional basis based on the regions set forward by the accountable communities of health. And just a status update, we shortly after issuing the survey, we received a series of questions from participants and posted our responses to those on the website. And part of that was to extend the deadline for response to the 19th. So plans still have a day and change to respond, and we've received 2 thus far, and I expect we'll receive the remaining 3 by the end of the deadline. Next slide, please. We'll be following up with a survey of the non-managed care organization health plans throughout the state. We aim to release that this week, and the purpose of that survey is primarily to track progress in the commercial market towards our paying for value goals. Again, we want to see 50% of the commercial market in value-based arrangements by 2021. We aim to release that this week and are finalizing some of our contacts. We want to follow a similar approach as we did with the MCO contract or MCO survey, where we sent the survey directly to plan executives and some policy folks to just target the dissemination. Let's see, next slide, perfect. So now to the provider survey. Again, we want to use this survey to track progress and identify barriers towards value-based payment arrangements, identify some gaps and challenges facing providers when it comes to adopting value-based payment arrangements, and use this information to help inform and help ACHs as they develop their project plans. We used this group to gather feedback on a previous draft, and that was very helpful. I want to thank everybody in the room that provided feedback. We had a robust discussion at the last convening here and received a lot of helpful feedback and informative feedback through email and a few phone calls. So that was much appreciated, and I think it has led us to a point where the survey is in much better shape and much more amenable to the target audience, which is I think will help us get information that we will find useful and that our accountable communities of health will find useful. So the current state, it is a much simplified survey from the draft, the original draft that we sent around it. All the questions and boxes that we're asking to be filled out are contained in one sheet, and then there's a second sheet with a few definitions. We've pre-tested this current iteration with a couple of provider partners that have volunteered to help us review and test the process. So I'm going to pass it off to Joseph, who's going to walk us through that process.
Sure. So as JD mentioned, we did pass off the survey to a couple providers just to get one more round of feedback before finalizing this and sending it out. And the good news is that it was well received, that it was greatly improved, and they acknowledged the improvement over the initial version that we brought to this group a month ago. It does take about 20 to 30 minutes for them to complete, for an administrator to complete, so it is something that can be done relatively quickly and painlessly, but it has a lot of good information in there. The feedback that was given that is going to go into the next iteration, which will go into the version that goes out, is improving on some of the definitions. Some things still weren't exactly clear, providing some examples for some areas in addition to the definitions, just to make sure that we're being quite clear in what we're looking for. And then there was a lot of good input around how we can potentially expand on some of the enablers and barriers based on their own experience, and putting out basically our list that were in there before, adding some additional items as well as clarifying some of the ones that were already in the list. Besides that, there was, I think we were looking for the information to be provided as far as what the amount of VBP was in different levels across 3 different payer categories. We were asked to expand that and to make it a little bit more clear exactly where some of the governmental other type of programs would be falling in place, since it wasn't Medicare, Medicaid, or commercial specifically, which were the 3 that we were originally looking at. So we will make these final edits early this week to that template, and start the dissemination process shortly thereafter. JD.
Thanks, Joseph. And we do plan to administer the survey directly to providers to the extent that we can. So we're seeking to leverage our relationships with associations throughout the state and organizations that have direct contact with provider groups. We're hoping to reach administrators in provider organizations to alleviate the burden that clinicians might face in completing this. I think that is a good approach, but it also poses some challenges because most of our contacts from the healthcare authority's perspective and a lot of our partners are clinician contacts, and we don't want to overburden them and ask them to find administrators within their organizations. Rather, we'd like to make that contact ourselves. So I'm going to pass it off to Mark to provide a little additional context into that approach.
Thanks, JD. This wasn't intended to be a lengthy discussion item, but I would invite any feedback from any members of the group. We are, and this is based on the feedback we got from you last time, targeting administrators, not trying to send this directly to clinicians to fill out. But that does present some challenges in terms of identifying the right folks within organizations. We've asked for help from our ACHs to provide us with any contact information that they have. We've engaged associations, Medical Association, Hospital Association, Behavioral Health Council, and others, and we'll work with them to try to get the survey out in front of their members. But if there are any other particular avenues that the group can think of to recommend to us that we pursue, we'd be very open. And it doesn't have to be live right now. You can send us your suggestions or catch myself or JD at the break and let us know. But it is a challenge to figure out when you say, well, we're going to do a provider survey. First of all, who all do you mean? Where are they? How do you try to assure that you're not going to hit them with repetitive requests? So we're trying to be both sensitive to the nature of the request, but as comprehensive as we can be in terms of our outreach. So especially any of you who've had experience with these kinds of surveys in the past, we'd welcome your feedback. So thanks for considering that, and please do think about it and catch one of us later on if you have ideas. With that, sure.
Are ACHs going to be able to receive not the compiled data, but the actual surveys themselves for the providers within their region? Has that been discussed?
I believe our messaging has been to the respondents that we would share information in the aggregate. I think that's what we've promised so far, right, JD?
That is correct. Yeah, in the aggregate. So we wouldn't be able to share, provider group specific responses.
So
we could
ACHs
consider.
are going to have to go out and resurvey them on the same issues?
No, I think we could explore and discuss, and we might need to add some language in the opening, but I think if there's enough responses, sufficient responses within each ACH, that we could aggregate that information by region, but that would be reliant on getting sufficient numbers of responses so that it's not identifiable.
So if it's going to be de-identified, you do realize that ACHs are going to go back out to these exact same providers and ask them a lot of the exact same questions. We just need to acknowledge that, prepare them for that.
Yeah, if there isn't a sufficient number of responses where we can share it and ensure confidentiality, I think that's going to be an issue. But ACHs wouldn't be would have the option.
I don't think you're understanding my point. It's not about, the point is that making it confidential means that we are going to go back out and harass them to answer many of the same questions they just filled out on your survey. If we can't get the identifiable information for provider practices, that doesn't help us do our work. So therefore, we are going to have to go back out, knock on their door, and ask them to answer a lot of those same questions again. If we could have the individual surveys that were actually compiled, we would stop bothering them about those questions, and we wouldn't have to harass them again.
Yeah, Don, you raise a good point. I think we can probably discuss that a bit further. For example, if we were to reach out to the respondents and ask their permission, basically, to share.
Or can the survey be administered with the understanding that this information is going to be used for ACH purposes as well? Or at least for the, can we identify the providers that make up our Medicaid, the bulk of our Medicaid providers, because they're the ones we're going to have to go back out and do this to again. And that's always been my concern with the survey going out, is we are experiencing real fatigue from the providers for all the people asking them for information, MCOs, ACHs, the states, their organizations. So we really are bumping up on all of us suffering by not aligning and trying to pull the maximum efficiency out of each and every touch with these providers.
Yeah, we could consider, for example, doing something, I don't know if we can do this within the survey document itself, but just asking them the question, can we share this information with your ACH, for example? Yeah.
At a minimum.
Yeah. Okay, thanks.
Could you share with us the rationale or the criteria for establishing to make this confidential? I'm a little bit confused on the rationale for that.
I think the rationale is that folks have expressed hesitancy to share this type of information, particularly the monetary and payment model information with us, if it was not going to be held in confidence.
In many cases, contractually, you're barred from doing just that. And so that's the obvious. I can see the benefit, though, Don, of sharing the information so we're not asking twice. I do have a question regarding the MCO data and the commercial. Will that also, the information, be available to this team or to this provider system?
In the aggregate, yes.
Perfect. Thank you. If you get more than one.
Thanks for that feedback. That's really helpful.
So Rick, Mark, I'm sorry. Just one quick question is, are we going to go through the survey again, or do you want the comments submitted offline on a different time and place?
We hadn't reserved much time in this meeting for a review of the survey document. And as Joseph mentioned, there will be a few additional adjustments to it based on the feedback we've gotten, but we could certainly, we will certainly send it out again.
I'll just catch up with Joseph later. Thank you.
Great, thanks. So I want to, thanks again for the feedback. I want to move us on to one additional update item. I'll ask Kaylee to just briefly talk about this.
Sure. So at the end of June, we received approval from CMS on 2 of the protocol documents that had been outstanding. This is the DSRIP, or the Delivery System Reform Incentive Program Planning Protocol, which hopefully you're aware of that as the project toolkit, and the Funding and Mechanics Protocol,
Both of these documents were submitted to CMS back in March, and there was some significant back and forth on just primarily getting clarification, making sure that CMS really wanted to make sure that they fully understood what we were, how we were designing this and the programmatic elements. So at the, while there was a lot of work that went on between March and June, the end product was not drastically different. There was a few areas where we made slight shifts, but overall, the documents from March and June were about the same. The exception to that is really the formatting of the project toolkit. And for those of you also who've been tracking this for a while, the project toolkit is something that we've been working on for a while. That went out for public comment in from January 3rd to February 3rd of this year. The feedback from that public comment was incorporated into the version that was submitted to CMS in March. The changes to the format was primarily in response to CMS comments for some clarity on timelines for when these activities needed to occur. So that was really the driver of that. That document did not go back out for public comment. Again, we were targeting getting CMS approval on that. Those materials are now posted to our website, so you are able to go and take a look at those. As I mentioned, the planning protocol is primarily the toolkit. The funding and mechanics protocol provides the methodology that will drive the incentive payments under Initiative 1 of the demonstration. One piece here to add, the metrics that are in the toolkit, we had added an improvement over self methodology for certain outcome metrics. So the way that the measures work, it's either a gap to goal approach or improvement over self. And the metrics appendix has each of those performance measures outlined and identified whether they are going to be measured on improvement over self for an ACH region or a gap to goal. So again, all of that you can find on our website. The other thing that had changed, if you had seen the earlier pre-approved version, originally there was a concept that if there was performance measures that were listed in more than one project, that measure would only, you could only earn credit for it once. That approach is no longer the approach that we're taking, and essentially that means that if an ACH has a set of 6 or 7 projects and measures show up more than once, incentive payments can be earned for that same measure more than once. So those were some of the highlights for those documents. Getting approval of these was a very huge milestone, allowing us to now really move forward with continued ramp up and implementation of Initiative 1.
Thanks, Kaylee. Those were our update items, and with the group's permission, I'd like to proceed to the next agenda item, which is really kind of at the heart of our meeting this morning, and that's provider capabilities needed to be successful in value-based payments. I'm going to turn it over to Joseph and Haley.
Sure. So I'll kick us off, and then that's loud. Then I'll pass it over. Oh, great. I'll pass it over to Joseph. So looking at slide 12, we have kind of a sub-agenda here, given that so much of our time today is going to focus on this topic. You have seen probably in emails from Mark, and on the agenda here, we do plan on having a somewhat lengthy breakout session. So after some presentations on our part, we're going to each break out into a group and dive in, and Joseph's going to provide a bit more information on the specifics of that breakout, but that's just a heads up. So before we get into the specific capabilities and key elements, oh thanks Joseph, and key elements of each of those provider capability areas, I wanted to just set the scene, and that's if we flip over to slide 13, at the goals for our discussion today, discuss a little bit the context and also the specific output of the discussion. So the very first bullet here is just revisiting the 2 key points that we discussed at length during the last meeting. That is that District provides a great opportunity for providers to build capability
and the infrastructure needed to participate in and be successful in value-based purchasing, but also that VBP can reinforce and sustain district projects and district investments in the long run. So we really want, we don't need to discuss those anymore, but that was something that we spent a lot of time during the last meeting walking through. I think they're going to remain key important points, and it would be helpful to keep those points in mind as we discuss what it is that providers need to even begin to engage in or succeed in VBP. In addition, I'll just flag that HCA received a couple comments since the last meeting from folks from the community, I think in response to the project plan template, highlighting just the need for both providers and ACHs, among other stakeholders, to really understand what is required by value-based purchasing, and that tees up our conversation today. I think that, and I hope you agree that there's real need for us to have a more concrete discussion of what providers need to start focusing on and start building in order to be active participants in value-based purchasing, no matter the type of VBP, and we'll talk a little bit about that in a second. So shifting over to what the goals of our discussion are, the specific outputs, you'll see that what we're going to go through today, we've got 5 VBP capability areas with key elements of each that Joseph's going to present, and that we really want your feedback on, and that's the real purpose of the breakout session. Based on the feedback we get on those VBP capability areas, we plan on putting together what we're calling an actionable tool for ACHs and their partner providers to utilize, to say, what is it that I need in order to participate, to take on this level of risk, and how might that change as I look to take on more risk over time, for example. And then also, as part of this conversation, what is the role of the ACH in helping to get providers developing the skills and capabilities they need for in each of these areas that we'll talk about. So that tool will be shared with, again, it's going to incorporate the feedback that we've got here. So we've got actually a meeting with the ACHs next Monday. It won't be ready for that at all, but at some point in a future TA session, we'll want to present that tool to the ACHs and also make it available for them to, again, use with their partner providers. Something else that's the final bullet here that we wanted to highlight is that, in addition to what Mark mentioned earlier on the MVP Action Team charge, as something that is a key part of the charge is the MVP Action Team members sitting around this table, helping to assess current state readiness for VBP in their communities and in their regions. ACHs are required to prepare a regional VBP transition plan that folds into it recommendations from this very group related to value-based purchasing. So to ensure that the plans that are going to be developed by the ACHs accurately reflect current state in their region and the collective thinking of this group, we do want to just encourage, and we'll discuss this a little bit later, MVP Action Team members here engaging with the ACHs between meetings. And so one of, this could be calls and conversations that you're setting up with partner, particularly active partner providers, with ACH staff, with even your own staff that are working in the communities and on the ground in the VBP area. We think that, I think we've put down here that it's, we'd like for you to incorporate the discussion and the feedback on the provider level capabilities in your own kind of informal qualitative assessments of VBP in your community. A qualitative assessment sounds a little bit scary, and we don't mean for you all to each conduct your own survey or have your own study of what's going on in your community, but we want to just put in everyone's minds that we would really like for the members of the community to be, for the members of this group to be having conversations between meetings on value-based payment and trying to kind of move the needle in between these discussions. And before the next meeting, incorporating in that ACH engagement the very capabilities discussions that we're going to have today. So moving on to the next slide. How did you do that? Thank you. I don't think we need to spend a lot of time on this, but we just wanted to have
in front of you the APM framework that Washington is using. It's from the HCP LAN. JD already referred to this. I know he presented it in many meetings in the past. But as you'll recall here, we've got ACH's definition of VBP being 2C and on, or up, I should say. I'll just flag that last week, HCP LAN released a refreshed version of its framework, of its APM framework, 2017 version. I was just chatting with JD. There's not a lot of changes. There's, for example, a consolidation of 2C and 2D. There's an addition to Category 4. But as I understand it, we still want to keep this version of the visual, and given that it's what's referenced in the contracts with the plans and in various other HTA materials. But the overarching kind of categories of VBP don't change based on the updated LAN framework at all. So moving on to the next slide. Before we dive into the specific capability areas, we wanted to just revisit what we're calling the 2022 vision. And you all are familiar with this already, I'm sure, and I know that we discussed it briefly at the beginning of the meeting. But as you'll see on this slide, not only do we need 90% of provider payments under the state financed healthcare to be linked to quality and value through a VBP arrangement by the end of 2021, we also have some subset goals that focus on APM-based, alternative payment methodology-based arrangements that are just fee-for-service linking to quality and value that are in that third, or I guess technically fourth row of the table that you see in front of you. So by 2022, we need 50% of payments made under the state financed healthcare to be linked or be made through the LAN categories in columns 3 and 4. So that's using kind of, it could be bundles, it could be capitation, et cetera, not just merely fee-for-service with some quality bonus payments. So JD, would there be anything you'd want to add to this before we move on?
No, I think you covered it.
Okay, great. So I think with that, the next several slides that will hopefully, oh, I'm sorry, I've got one more here. This is exactly what I was going to say, tee up our kind of more in-depth conversation on the 5 VBP capability areas that we want to walk through. The point of this is, we understand, as we were just talking about, that APM or VBP has different levels of risk. Like in a VBP arrangement, you could be taking on no risk whatsoever. It could be all upside. It could be downside with quite a lot of risk, full risk. That there's tons of different types of value-based payment arrangements and different levels of risk that a provider can take on. But with all of them, there are just some underlying capabilities that providers need in order to succeed in a VBP arrangement. Some of them require pretty substantial shifts in behavior, and we're going to talk about that today. The whole purpose of this conversation is to get the group around this table, or whatever you'd call this, thinking about what are the specific areas that providers need in order to participate, not just in a shared savings arrangement, but also down the line in a more complex type of value-based payment arrangement. Joseph, do you want to take it on? I'm going to pass it over to Joseph, who's going to go through each of the 5 areas along with the key elements in each.
Thanks, Haley. So I want to tie just a couple of things together as we get started here. At the very beginning of this, Mark went through the charge, and I wanted to highlight in that charge of this group right here is it's to serve as a learning collaborative, specifically a learning collaborative to support the ACHs. ACHs have been asking a lot about value-based payment. How does it fit in? How does it fit in with what their role is, and what are the capabilities that are required? To that end, we wanted to put together some technical assistance materials to really help educate them as well as the providers on what it is that they need to do in order to be successful. And what better place to talk about that than in this group of the experts that do it, that is serving as the learning collaborative to help educate those. So there's good news and bad news. The bad news is that this is going to be a working session. We really want to try to pull information out of all of you and to help update this. The good news is we're not starting with a blank piece of paper. We brought some materials on how we're thinking about this, and we really want to invite comments, edits, additions, deletions, feedback to really make this very specific for here. We think that this is a good starting point, but again, a number of organizations here, whether you be an MCO or a provider organization, are participating in VBP right now. You know why it's working, you know why it's not working, you know what your barriers are. Hopefully these capabilities resonate with you as the right ones, and if not, let's make them the right ones and really move forward. So with that kind of setup, this slide right here is just an overview of how we're thinking about them. And in order to do anything from an educational standpoint, it's been my experience that if we kind of keep it simple as possible, it actually helps with the learning. So we have these all bucketed into 5 general categories with a number of capabilities listed out in each category. So the way we're looking at this is governance and organization. And when I talk about governance and organization and why that's a capability for VBP, you have to think of it from the organization that is doing the contracting for VBP. Is it an individual provider? Is it a large provider system? Or is it like an ACO? Is it a whole region that's banding together to do that contracting? That's the level that the governance needs to take place at. But I don't want it to get lost that governance is important even if it's one organization, making sure that the contracts that are being signed and the things that are being put in place are actually what is the culture and the organization the providers are actually doing. And that leads into the next one, and actually these two go quite hand in hand, which is the provider engagement and making sure you have that network of providers that are associated with that VBP contract to make sure you are able to achieve the result of it, whether it be on the lower end of the scale around 2C, which is around VBP and quality, just making sure you're hitting your quality metrics, or when you go up and you start having shared savings participation or shared savings and losses as you keep going up further all the way up to the road of capitation. You need to have that network of providers engaged. And again, the importance and challenge of that comes depending on how large of a contracting entity this is and whether it's a region, whether it's an organization, or whether it's just an individual provider. Care coordination and management is just that. It's really looking at how you are setting up your evidence-based management, what policies, procedures you're putting in place, how they're being defined, how you're setting up your care protocols, how you're actually doing the care management yourself. MCOs do a portion of this and today, and they will probably always do a portion of this. The deeper you get into value-based payment, the more important it's going to be to have that done more at the provider level. Population health management. This one's going to be a little bit confusing for you all, and it still is for me, so we definitely want to ask your input on this. We're using this definition right now the way that the district program is starting to use it, which is all of the technology related to population health management. So I want to make sure that's clear. You'll see in here everything from data exchange or health information exchange to data aggregation to reporting to population health. It's not the care coordination components of that. We've separated that out in the previous bucket, the care coordination and management. So I know that terminology may be a little bit off. If we can improve that terminology, we would love to get your input on how to do that. And then the last one here is something that we feel very strongly about, which is the links to the social determinants for health. How do these impact the communities? How do these impact the health of the communities you're serving, and how can that help you in your VBP contracts going forward, specifically with the populations that we're dealing with under the district program? So with that, the next concept I want to bring up in this training is that where you are in these capabilities changes depending on how much risk you are taking, and I should say you could be at a low level of risk, could be very high capabilities in some of those areas, which is fine, but you can't really be at high levels of risk and be at very low levels of capabilities as we're defining them. Or maybe you can, but it'll be a lot more challenging to be successful. For example, if you don't have population health management or a strong care coordination plan and protocols and the people on the street to help with those processes, and you're in a full capitation arrangement, that's going to be a lot more challenging to deal with. If you are a provider in a large organization or a provider that's part of a regional contracting effort, and you don't understand what the quality measures are that you're reporting against, or you don't understand what your cost targets are, or what the protocols are, you know, something broke down in provider engagement, something broke down in governance, and so those are going to be important. The deeper you go into the levels of risk associated with VBP, the more important each of these capabilities are going to be, and so we wanted to try to highlight that And these first two graphics were really just to be that overview of what those capability areas are with some of the subsets and what the level of increased need and capabilities required would be for VBP success should be. The next 5 slides are going to, or actually I guess it's like 7 or 8 slides, are just going to go over each of these areas in some detail. I'm going to spend a little bit of time walking through each one of them, and then the next thing we'll do is have a break. And after the break, what we're going to do is divide up into groups, with each group taking one of those areas and basically providing their input, feedback, and thoughts on how that area can be modified, updated, things added, deleted, changed for that. Questions before I move on? There's my. Okay, governance and organization. You know, again, I've already talked about this a little bit, really needing a focus as far as what the VBP contract entity is and where the governance needs to lie. But there's things that I want to highlight as being important in here, which is identifying your provider network. Now, right now, if you're an individual provider contracting the VBP relationship, that's up to the MCO to put together that network. But if you are doing something on a regional basis, or if you are doing something as part of an ACO or a larger provider organization, that's your responsibility now. And so those capabilities change not only with the level of risk, but also with the kind of organization that you're in. Things that are important in making sure you're successful here, we've identified as referral management, engagement to with physicians and non-physician staff and organizations. A lot of this can also be with social workers and such, to make sure you have that full network in place. Co-location, we know that that's a very important part of DSRIP, as well as the, what's going on here in the state right now between behavioral health and primary care providers. And then one of the things that we think is one of the most critical roles of governance and organization, and it kind of straddles, oh, I'm actually on the wrong slide here in front of me, is performance management. It's still the same one, and there's going to be a link to this in the next one too, with provider engagement, because really performance management and being able to have the access to the information, being able to manage the providers and the different entities that are involved in your VBP contract become critical in order to lead to success in those areas. Change management. In order for an organization to move from a complete fee-for-service world into a new type of VBP arrangement involves a serious culture change. I think if you're looking at it from a large provider organization, for example, that maybe has hospitals and things involved, saying you're doing things that's going to eliminate utilization on one half and eliminate fee-for-service revenue is challenging, especially when you're replacing it potentially with shared savings, which doesn't equal what you're losing in what you're doing, so you have to capture that capacity somewhere else. There's lots of change and lots of education that needs to go on in an organization in order to develop the culture, to deliver the quality, to deliver what's necessary to achieve the results of what these VBP arrangements are looking for. And then I think legal evaluation and contract management goes without saying, not just with the MCOs, but also with the various providers and the various entities that are involved in contracting as it goes on. If there are payments that go downstream to providers or to other organizations, and how those are managed as well. On the right-hand side of this slide, we wanted to get into, again, the degree of capability and how it changes by level of risk. And I think I've talked about that with this one already, but it's highlighted on here as well. When we ask the groups to start looking through these and providing their feedback, one of the things we're also going to want them to consider is, what does the ACH do and contribute? How can the ACH assist in their region with these capabilities? And governance and organization is probably one of the strongest areas where ACHs can play a role in here in bringing groups together. So please give that some thought as you're going through this. Questions? Okay, let's go ahead and move to the next one, provider. So I mentioned that I feel at least that provider and governance goes very hand in hand with each other, and this is really making sure you have your network in place, the referral management's in place, co-location. I mentioned some of these. I was reading some of these off of the prior slide. So managing the providers is becoming very important. Providers need the feedback in order to be successful in these arrangements. They need to have the incentives in place. Whether you're in an organization, however you incent your providers versus your pay structure, or if it's a bunch of disparate organizations coming together in a region or under an ACO, how are those provider organizations awarded? for their level of effort and what it takes to do this, or their payments for non-reimbursable services that need to happen up front in order to get the change in place. Are there shared savings that will be shared broadly and with providers participating? Again, maybe shared savings, maybe quality payments. And then reporting, what kind of reporting are you able to give to them? What reporting are you required to get back from them, especially with different organizations on different systems? If you don't have things tied together right now, how are you going to manage some of those now? As you're in lower levels of risk here, I think getting the providers together and the agreement in place are important. Talking about what the quality measures are and getting buy-in on that is going to be important. But when you get to higher levels of risk, where you really have to be strong at your network management and making sure you have the right providers and they're doing the right things, and when they're not doing the right things, there's the appropriate ways to deal with underperforming providers as well as those that are achieving the standards and beyond. Maybe there won't be any changes this time. Very quiet group. Okay, care coordination and management. As I mentioned, the way we're thinking about this really is around the tech, or I'm sorry, this is around care coordination and management. I'm jumping ahead. I'm always a slide ahead of myself. This is really putting those items in place that help with the care coordination. So this is a coordination across specialties and sites of care. How are those handoffs handled? Are there systems involved? Are there care managers that help and assist with that process? Care plans, when you have a high-risk population, when you have folks with multiple chronic conditions, do you have care plans for them? How are they being managed? Who's managing them? And how is that information shared across multiple sites of care that they may be involved with? Involving the patient in their care is critical to successfully managing this. And how are you going to engage with them and make sure that they are a party in their own care and doing the right things, taking their medications, utilizing services in the appropriate format that's out there, making sure that they're not going to the emergency department when they need a refill, that there's different locations that they can go to. And then, at the core and the heart of all this and the foundation is really what are those evidence-based care management protocols that you're putting in place. Having those documented, having those defined, going back into the previous one with the provider engagement, having the providers engage in those, going back to governance, having the governance structure, enforcing those and making sure that those are in place and used, really the foundation to being able to do this. And even as you're starting off at the very low levels of quality performance, and when I say low levels, I'm talking about as the LAN framework defines them, but as you're in VBP with quality arrangements, which is the lowest level that you can be to be recognized as VBP for the purposes of DSRIP, you need to start identifying what those are and how you're going to achieve those various quality standards and getting those agreements in place and making sure you have the links that across different provider type organizations, even to the pharmacy level involved.
So Joseph, I have a question. I don't know if it's for later on this group on this particular topic or not.
I can't see. Oh, there you are. I'm like, here. Who's talking? I'm just hearing sound.
I know,
it doesn't.
It's hard to locate. But when you go into care coordination, I think it's actually a matter of also, payment or your fiscal alignment. Because one of the things that we run across, 5 years ago when we did reduced emergency room utilizations by 12, 15%, then the hospital actually got upset because we were taking money out of their pocket, and no one actually gained from it except for the managed care organizations, I guess, because we didn't get any money back on the savings. So, when you flip these switches, is there thought given the fact that A is contingent on B, because if you don't do it, this is really all, this will become a loss real fast. No one's going to engage in it because just like we did, people lose interest because they don't have financial stake involved.
Yeah, I think that's a really great point. And, maybe the whole financial play in here isn't spelled out enough. And
well, I think that one of the things that we talked about as part of the governance and oversight piece was that ability to, be it at the VBP contractor level, be smart about your contracting. And to Joseph's point earlier, think about how you are going to be rewarding if it's downstream providers or you yourself, ensuring that you're going to benefit financially from participating in this sort of arrangement. That's where I see it fitting. I think that what you're highlighting is that's a kind of an effect of effective care coordination and management. I don't know, do you agree, Joseph?
Well, I think it really depends. And so I think maybe what you're talking about is your contract was for your organization, but it didn't involve the hospital itself. Is that correct?
No, we involved the hospital and they got on board, but then once they realized that we're taking a cut of their pie, then they weren't so happy to be involved and they kind of stopped showing up for meetings.
Right.
I mean, it's not their fault because this was hurting them financially and they wasn't to their advantage per se. Until we make that happen, I mean, what the hell?
It's interesting. And I'll just bring a little bit of flavor from the New York experience out. As they were setting up their district programs, one of the required funding areas of district funds in the transition from fee-for-service to value-based payment was revenue loss, because they realized that hospitals were going to lose ED utilization, inpatient readmissions, things like that. The right things to be losing from a quality perspective, if you imagine, but it was going to create real revenue loss. And even at 5-10% reduction in headcount, you're talking about a person a day. You're not shutting down a ward. You're not changing your staffing plans. You're not doing anything in a hospital to address that, but it's still real revenue that's walking out the door.
So let me challenge that, because from 2006 to 2016, across the U.S., there were 61 hospital closures, mostly in the Southwest, mostly critical access hospitals. And, the thing is, like I was in a meeting on, Friday, I guess, the Health Innovator Leadership Network, and, I forget the CEO of one of our major hospitals, my question to him was, so, are you prepared to have part of your hospital closed down in response to this? Because technically, if this is successful, hospitals are going to become archaic and actually diminish in numbers significantly because they won't necessarily be utilized and won't be, if we are successful in doing all the upstream work in population health management. That's a huge cultural shift, but it's also a huge fight against a strong, heavily vested and lobbied entity that's politically connected more so than I care to dream about. So, I mean, this is a hell of a fight, I think.
So my understanding of what we're supposed to be figuring out, and we're all living in dream world right now, right? We're just drawing the crap on the wall, is how do we find a way for the hospital to provide services of value that they can get paid for, that ultimately at least smooths out that loss of the ED or the unnecessary use, and that the ACHs in some way serve as that safety net during that transition period. So we're at point A today where they're making revenue by turning people through an ED. We want them to stop doing that. That potentially for some hospitals will mean a loss of revenue. What else can we get them to do that we value them doing that actually has a greater benefit to the entire system that we can pay them for? And how do we transition them to that? And how do we cushion the blow until they get there? Now, what we pay them for to do and how we get them to shift to provide services that are of value is really the elephant sitting in the middle of the room on that question. But in my head, that's the model on the whiteboard, but I don't know the answer to the question. And that's like, what can we get the hospitals to do that would help shift their model and keep them able to survive and provide the services we still need them to provide?
These two comments are really excellent, and it only took about 20 minutes to get right to the nucleus of the thing that we're all struggling with. I would like to see a show of hands of people around the table who have direct experience with the problems that are being described here. Direct experience. Okay, so there will be a lot of learning in the breakout sessions, I think. We are going to be dealing with this problem. My initial comment was a rational person would have a single payer system in the country and not fee-for-service. We are trying to unbraid a very complicated, dysfunctional, misaligned payment system that's accrued over the 80 years of this country. And we are trying to do it without putting hospitals out of business inappropriately or other provider groups. It's not just the hospitals, it's multi-specialty provider groups, either owned by hospitals or independent. They all have similar or different but similar themed problems. We have to figure it out. We're not in the business of trying to put people out of business. We don't have enough primary care people in this state, for instance. So this is it. Thank you for articulating it, you two, and we're going to be talking more about it.
I have a much more mundane comment now with respect to this portion in particular. I think we're going to have to figure out a way to redefine care coordination because there's tons of confusion between care coordination and community care coordination. And because the project toolkit specifically calls out community care coordination as a project area, I know in my region and with our stakeholders, we are really struggling with clarifying the difference between what I've started calling clinical coordination, medical coordination, however you get that. This is really about the actual clinical care piece as opposed to the community care coordination, which is really about connecting up with social determinants of health. And when we use those terms, you know, broadly, I think we're starting to really confuse folks and lose folks in their lens of what we're really talking about. I don't have a solution for a new lexicon, but I think if we came together and came up with one and started to use it, it would be helpful.
So that's a missing lexicon right now. Okay.
I just wanted to also flag the provider engagement piece, which I think is really important for us to think about both in terms of care coordination, but when you start talking about quality measures that have in their denominator the entire population of assigned Medicaid patients to a practice, and we know many practices encounter 25 to 30 to 40% of the patients that they're not successfully getting in and engaging in primary care. I think that's a real challenge, and thinking about how can we engage those patients either through other care coordination efforts, but that's very challenging for provider organizations as they look at trying to achieve those quality metrics with a population of patients that just have never presented for care.
Got it. Thank you.
So beyond just thinking about the capabilities that providers need to have in place, thinking about how we can solve some of those existing problems, like patient engagement as a part of saying, as a part of motivating a provider to get engaged on this sort of thing. That's a great idea.
I'm a little worried about all of the classifications here being too siloed to just providers. I think a lot of what, at least me as an MCO, when I'm out in ACH world, talking about how to transform the system, we talk about is creating a team-based care approach that involves different parts of the health system outside of the provider. And I think that we already have some demonstrated success with certain providers maybe in this room in trying to work both as an MCO with other MCOs and with providers to create a comprehensive and spectrum of what team looks like. And I'm missing that in this presentation a little bit. It's feeling too siloed to me. I think also I am a huge fan of single payer generally, but I think what Medicaid expansion taught us was our population in this state and in this country is way too unhealthy to move to single payer right away because we just can't possibly manage the risk of that. And I'm also reading in American Sickness, which I can tell you is super depressing and makes me very cynical about how successful this is all going to be, but taking lessons from that, because we are in a more capitalist healthcare system at the moment that's more business oriented, I get a little worried that, and this is just a general comment, out in the communities we're starting to hear a lot of prescription around you should all be moving to this particular VBP model, and I worry that this classification of services or capabilities into different models is going to enhance that conversation, because we actually need a diversification of VBP models. We can't just all move into one, because then you're going to drive up costs faster because you're going to give market share and market power into different entities that will make costs more expensive. That's how,
How capitalism works. So I just want to make sure that we're having an honest conversation about that as we're moving forward with these capabilities so that we can be aware of where that diversification can come in.
Thanks for that comment. I think this is a real opportunity to kind of suspend Northwest nice. It's really an opportunity to speak clearly, succinctly, honestly from your own experience. And there's a lot of experience around this table. And the comments that have come forward already is the tone that we're really looking for. This is how we make progress, because we don't all see it the same way. But collectively, I think we'll have to carve out what the solution will be going forward. The solutions will be going forward.
Yeah, as I'm coming from New York here, we can all speak like New Yorkers. So yeah, I've been in these similar meetings on that side, and it's a lot more pitched out. I was going to say in response, that's a great comment, Caitlin. You know, I think at the beginning of this conversation, we said, when we're having these discussions, let's think about the role of the ACH. I think you're pointing out, let's also think about the role of the MCO. Let's think about the role of others on the team. I think we should be doing that. I think we still do want to have a little star next to the ACH, because part of our charter is to kind of help form what they need to be doing, given that they're newer than MCOs. But it's an extremely great point about the team, how we define team. A lot of these are things that MCOs are currently doing, have lots of experience doing. So I think that's a good addition to the breakout session instruction.
Going on to the second half of this, I've said this a couple times now, just as far as how, again, care coordination management changes from the early lower levels of risk type of VBP arrangements, which could just be around quality measures, to going up to a category 4 where it's full capitation, and you need to start dealing with how you're going to manage downstream providers and how you're going to be able to manage the care and how that's coordinated across multiple diverse entities if you're paying for those. Population health management, again, just to go here, these are going to be very technically related, just as the way we're defining population health management, but this can't be understated. These are some of the strongest capabilities that are necessary out there, and we do have a number of different components in here, performance monitoring being one, the data aggregation, being able to pull data from multiple providers, multiple locations in order to manage a population of help is being provided, data exchange being between providers, having the care management systems in place that aren't the electronic health records, but it's actually the care coordination and the care plans that a patient may have for them that isn't just within one EHR, it's across multiple providers, potentially depending on what the different chronic conditions that a patient may have being managed. How you're going to look at your patient, how you're going to engage them comes from these types of systems, how you stratify them, how you identify them, how you make sure they get in to see the primary care physicians in the first place. You need to identify those populations, those people who are having multiple emergency room uses, who do have multiple chronic conditions, but who don't have a primary care physician or hasn't seen one in 18 to 24 months, and making sure that they get engaged. These are the systems that really make this important. And these capabilities are challenging because if you're looking at this, really these things need to be in a regional area, it needs to be across providers. We're talking about a population of people here, not just somebody who's captured within 4 walls of a particular institution. So making sure, and this is where MCOs I think become very important, they have a lot of the information, at least from a claims perspective, on what's going on with these populations that contribute to any population health management system and are critical in order to manage the health of a population, as well as to manage the operations of that's being provided from a financial perspective and where the costs currently lie. As regions are looking to do things, it's challenging because there are limited funds, and adding new systems on top of existing systems is always difficult. So what can be used that's out there right now? Are there any systems that are in place that can be expanded or used, or is there things that can be put in place even across regions if there is something totally missing? I was in a conversation about 4 weeks ago now where the idea of a rural health exchange for the state of Washington became very important because there's a lot of areas that cross entire regions, multiple regions of people where they need to share in care because of just where the providers are and where the locations are, that it can't be even within a region, let alone within a single organization. I see people reaching for red buttons, so I'm going to pause.
I'm from New York, and I don't think I've ever been accused of being Northwest nice. I have something to strive for. I think on a number of the issues that are appearing on all of these categories, we need to collectively decide if dealing with the strategies that underline those capabilities is going to be a statewide endeavor, or if regions truly are going to be taking that on one by one by one. You know, in particular, I come from a health IT background, so it's easy to pick on that. You could also throw in their workforce. You could, you know, probably pick through and find some other areas where I think we really do need to have a collective conversation of, you know, what are we willing to do collectively as a state? And I don't necessarily mean that just as under the banner of HCA or the state, but collectively as the state of Washington working on this initiative, including HCA and the rest of the state government piece. And what really are we expecting to do region by region? And I know from my perspective, I need to cost that out. Because if I'm going to be building out particular technology structures, especially around HIE, that are regionally based, that price tag is going to diminish my ability to utilize those incentive funds in other ways. If I'm going to be investing dollars in regional workforce strategies, then again, I'm not going to have those dollars to utilize in other ways. And not knowing how to cost that out is really a roadblock to moving to some of the funds flow modeling pieces. And I think is going to be a really difficult conversation for the MCOs with providers in each region to know what can you actually ask of them if you don't know what they're going to be provided with. The other point I'd like to make is, and maybe this is later in the slide deck and I'm cutting you short, so sorry if I am. This requires an intense amount of training, coaching, education, constant, like on the ground hand-holding work to shift how our system is currently working to actually fulfill these capabilities. Yeah. And I'm not seeing where that assistance is coming from. So once again, is that an ACH provided experience? Because if so, I got to get my calculator back out. So really being clear as to what is being funded elsewhere and really what is coming into the ACH bucket is critical for us to successfully model this out.
I think those are all excellent points. And, change management was two tiny little words hidden under governance in there, and it is a much bigger deal. And then you actually went a little bit further and even went into workforce and the things that go around that. And those are important aspects of all these programs, where they're based, where they're funded from and through can change, I guess, based on capabilities of a particular region, and where maybe a region has a very large organization, provider organization that could be the basis for it. Maybe they don't. It can vary quite different in different regions, so I don't think there's any standard or pat answer other than those are capabilities that are going to be required and need to be thought about, and how they need to be funded needs to be fit to the region, and it may require a calculator depending on what's necessary.
And that hasn't been clear. That's the problem, is that it hasn't been clear what is the regional responsibility through the ACH and district funds, and what should not clearly be the ACH's financial responsibility, and where there's other elements that are going to be covering those expenses. So if we could drill down on being really clear as to what is not in the ACH bucket, at least, would at least be a step in the right direction.
This really is a big deal, and I am also was originally from New York, so let me just give you straight off the top what I'm thinking, and I think maybe some others are as well. We're in a competitive competition model today. There's nothing in anything we're talking about that would move us away from that. So when you look at what is required here, which is absolutely essential to moving to any kind of successful value-based purchasing, whatever you want to call it, model, this is the underpinning. Without this, fully developed, ready and used out there, none of this works. So what you, in my mind, we get to is an important design and policy question. There is never going to be enough money for the ACHs to do this. It's just not going to happen. This is extremely tens, if not hundreds of millions of dollars worth of investment to do this. So what does that mean in a competitive competition model? That means that if you're a provider, you're going to access this data either by becoming a member of an integrated delivery system or through an insurance plan. And it's that affiliation that's going to give you access to that data. If you're outside of that, you're outside of the picture and you're not going to be able to successfully participate. And that's one of the roads we're heading down, and I think we have to look at and think about that very clearly. The alternative might be some sort of utility model that would allow everybody, including no matter where you are in the state, or whether you're a critical access hospital or one of the surviving critical CHA critical access hospitals, or a small rural provider, you could have access to the same data anybody in the community has. But again, there is a funding infrastructure question, it's a policy question that I don't see us really addressing.
I think too, along those lines and taking it a bit further in our policy systems design discussion is, I agree with all of this and that it is crucial to success of anything related to VBP. But I think too, so many of our metrics currently are utilization based instead of population based, and that's a different kind of conversation. How do we move to a more population, if we want to? I think that's the first question. Do we want to move to more of an incidence or population-based quality metric system? How public health more likely does it? And if we do, then what does that mean for changing our metrics and getting people in creating this infrastructure used to that kind of system? Because a lot of the ACHs currently, or not a lot, but I've heard it at a couple, when they're even talking about how to do distrip or trying to figure out the need in their system, they have some real issues in identifying the unmet need in their community. And we've had that problem in rate development as well as MCOs, trying to make sure that when assumptions are being created for our rates and our actuaries, that we can address unmet need. And that unmet need is pretty important, because otherwise we're going to continuously have access problems if we don't know what the unmet need is. And some of the adjustments to getting to more population-based quality metrics may be able to help identify unmet need and also link both the healthcare, very specific care system, clinical system, to more of a public health population-based management system. So it would be nice to see, or if have a conversation about whether or not that's the direction we want to go, and then see that built into how we build that infrastructure up. It may not be the direction we want to go, and we should confront that as well. It may not be possible at this point in time.
I think these are going to be lively breakout sessions. I'd also like to throw into the mix, only because I have talked to hundreds of physicians over the last 40 years about data. Data for what? Data for whom? To what extent? This is I have no agenda here, but to what extent are the data we use that describe utilization, data that come out of claims payment systems, are we using that data because we are trying to get upstream with a fee-for-service based industry? How much of that data are required for good utilization care management? What's not? And then from the clinical perspective, what data do you really need? Which every time I hear HIE, I start bristling. And I know why I start bristling, because I've been trying to cracked that nut for 14 years and tried one myself in a network of physicians, and finally hit the wall. And the wall was, I'm a physician. I have liability. If I'm seeing a patient for the first time and they're coming with a load of data behind them, I don't know about the validity of that data. It might be 6 months old. It might come from a place that I have no idea about the context of that person's condition. I need to start from scratch if I'm seeing that person for the first time. So what are we building HIEs for? Again, it's back to the administration tension with clinical practice. And I think that's an issue that this group can deal with constructively as well, because it relates to much of what you're talking about cost of new investment versus repurposing and redirecting resources, which is going to take time.
One of the questions I always get from our clinicians when we start talking about HIE or talking about population health management and the IT is, so how will I use this tomorrow in my practice? How will this help me make clinical decisions? And I think we need to differentiate between two very distinct types of information products here. One is what I think we talk about mostly, which is retrospectively, how do we use this to carve up the money? And how do physicians use this to treat patients? And that seems to have short shrift in most of our thinking, but that's what's actually going to have the greatest impact towards achieving what I think we're really talking about. So I think we need to be thinking about that, and we think about our investments and think about where that data lives, because that gets into some pretty sensitive as well as some legal entitlements in there that have to be considered.
I would agree with that and add another layer. I think we talk, provider is a word that encompasses clinician and also provider group and organization. And I think that there's another layer of where the data is used by the non-clinicians in the organization to get the person into the office tomorrow. And that's another important component of all this.
And I'll take it even a step further, going back to Rick's point, is perhaps one of my concerns is that the data that we collect is a lot of times is processed data. And really we want, I believe, if we're going to go to value-based purchasing, we just need to focus on outcome data. And for example, my agency is subjected to the worst of both worlds. So we are subcapitated, but we also are subjected to essentially fee-for-service data analysis to support the capitated rates. So we have to do both ends. It seems like if you want outcomes, we should identify those and go with that and use that as our measurement tool. But all the other things, all the other encounters we get data measured against, it's just kind of, it's quite frustrating and really detracts from the service delivery system that we're trying to make robust.
And if there's one place where ACHs, it seems to me, can make a difference, as I think about how are ACHs really going to fit into this puzzle and be of use, the data question seems to certainly be a primary one. Are there, I think about the EDDI system, other statewide databases, there's not many examples, but as we look to craft, as to Don's point, statewide HIE resources, to the extent we're going to do that, if we could be thinking about the value-based payment world as we go about that, this is a place where ACHs could definitely be of use. And I also think about data that the healthcare authority has access to that is maybe considered more proprietary in nature otherwise. Could the ACHs have access to some data that that might be, otherwise you'd have to go to 5 different managed care organizations to get? Could the healthcare authority help us access some of that data and use that in our communities to help inform our efforts? This is a place where certainly ACHs can dock in and be of use on the data question if we can support them in that with that capability.
If I can, Kyle and Don, your point really is something that we've had discussions, and it has to do with, does the ACH really have the capacity to do what's being asked of it? And maybe this goes back to your point earlier, because currently when we look at our current staffing, and we're changing our organization several times now, but every time it's based on new things as we learn from the HCA and what the expectations are. But the more I look at it, the legal component, the evaluation component, the performance monitoring, tracking, all those kind of things, man, I'm trying to amp up our ACH to do that is quite a task. And perhaps secondly is I think, I hope people realize that ACHs are, no disrespect intended, and the hell with Northwest Nice, but are immature organizations that are just budding into maturity and are quite diverse as far as their developmental stages of growth across the state right now as they exist. So I mean, I'm just like, wow, it's off asking an awful lot of a new, evolving, developing entity. And are we asking too much, or where does this? What can we do to make sure this is successful? Aside from, I don't know if we'll be able to grow that money tree fast enough.
I think in the breakouts when we start talking about the role of the ACH in these various areas, maybe it's not just focused on the what is their role, but it's also maybe where isn't their role. Because I think you're right. I don't think that the money is enough to stand up brand new tech-strong organizations that are going to provide this for entire regions. I don't think there's any money in there to build it, let alone sustain it after the district funds are gone. So I think reuse is going to be important in other concepts. So there needs to be a clear articulation, I think, of where we think the expectations around their roles should be versus where they shouldn't be.
And just to answer your question specifically, there needs to be parallel tracks in terms of short-term versus longer term. Yeah. You know, can we out the gate, you know, January 1, do what's being asked of us if we were supposed to be hitting year 5 targets? No way. I wouldn't be here. I'd be far gone. But there is a ramp up. And if we can get a longer term plan in place and start working on connecting the dots to have that plan ready for years 4 and 5, and an interim plan to plug some of the gaps short term so we can start evolving and building, I do think we get there. But there is you need a coalition of the willing to really sit down and say, what is the long-term vision and plan, and how do we get there? And it's not going to be on district funds. So what is available for us to leverage, and who wants to play in that visioning process and get that off the ground? So that's where I'm trying to push people to have their brains in very different camps as they look at this over the span of our demonstration project.
So just to bring things back around, and I want to finish these categories here just so we can get into the breakout groups. In relation to population health management, I mean, this has been a very robust conversation. One of the things in my experience that has been successful when nothing's in place currently is just getting the providers to get lists of patients that they need to go into care management, and developing those lists, being able to mine even within a single provider what those patients are, and funding some sort of patient outreach can lead to early success around payment for quality measures and even some of the other cost measures early on. But real population health management, as you go down this curve, as you're many years out, requires, as you can see on this list, a lot of very specific capabilities and systems to be successful. And a lot of those are kind of where MCOs have some things in place already that can potentially be leveraged or used or partnered with in various ways. Linked to social determinants of health. This is something we brought up, and this might play a little bit into what I heard earlier around defining what the team is and not being specific to just clinical providers, but this is about what are the other service organizations that are out there that can help the community and help this population that we're trying to serve to get what they need, whether it be housing or food or any other number of services that will contribute to their cost of health. I know in New York, social determinants were required to be part of any VBP program, so there had to be some sort of element and payment for a social determinant program within the contract of a certain level. And One of the things that we saw being put in place was around asthma, especially for children, and trying to make sure that there was community outreach and people going in to assess the homes of kids and educate the adults living in that home and see what needed to be done to fix up that home to help make sure it was safe for them from an asthma perspective. That was a program that was initially funded out of DSRIP, and hopefully if it shows success, it'll be included in contracts going further. But those are some examples of types of things that can be done that maybe aren't paid for today, but could potentially be brought into successful programs going forward. So again, as you mature in this, I think it's going to be, early things will be challenging to identify what are going to be the most specific, and I think DSRIP gives us a test base to try out a couple of things that can hopefully then be paid for in the longer term. Going to the breakout sessions, I know we're a little bit past our planned time right now. As we mentioned at the beginning of this, what we want is to divide the group. We were going to do it into 5 groups. There's a few seats missing here, so I think Haley and I have been looking at the people here, and we're going to end up doing 4 groups, and one of the groups we're going to give 2 topics of the governance and provider engagement. So what we're going to do is Missy's going to help set up the room into these groups. Generally, the groups are going to be where you're sitting because we had to combine a couple of the groups. There may be some people move, so we'll try to get the name tags into the appropriate areas. What we would like for you to do is to look through the information that we've kind of gone through, we've had some discussions about, and really kind of update it in 3 areas. What revisions to what there need to be made, things that aren't there that need to be added, things that need to be changed, deleted, whatever is important. Please identify for us what those are. How is this going to change over time? What's the importance today? What's the importance in DSRIP? What's the importance down the road? And then what's the ACH's role, what's not the ACH's role? And as we heard, it probably makes sense to identify what an MCO role might be in here as well, because I think that they're going to play a big role in all this, and they have been part of the DSRIP program and are a big part of what we're doing moving forward. We have put an MCO in each of the groups, so there will be that voice in each one along with the other folks that are in the room. I think we're going to have a little bit over an hour, I think it was. I think we have just a little bit longer than an hour for the breakouts to have, and then we're going to get back together and have somebody in that group to kind of present what they think the items are in this area for us to take back. Our end result is we want to take some of that and kind of iterate this technical assistance document further, and whether that's ready to then start turning into TA that will be used with the regions, or whether there's more work in this group, I think remains to be seen.
Okay, I'm going to jump in. So given our time, and we did promise you a break, so we will take a break before we go into our breakout sessions. But I also, John Doyle, who's one of our members but is participating on the phone, offered an observation, which I'll read. I think one important aspect not being discussed is payer mix. All organizations have limited resources. If the health system is 10% Medicaid, 40% Medicare, and 50% commercial, why would a provider spend resources on the 10% of their business? Maybe a rhetorical question, and John, apologies if there's additional information, please do submit it, but I wanted to make that comment. Let's take a break, and if people can be back in 10 minutes, that would be great. So it's about 20 till, so if you can be back at 10 till. Restrooms are down the hall and to the right, and we'll see you back here in 10 minutes. Thanks. You know, the Northwest Nice in me allowed the break to go to 15 minutes instead of 10, but I'm going to have to knock it off here. So I'll channel some New York stuff and say, get back to your seats.
Thank you. Thank you, Mark. Okay, I think the way we've had this broken out, and where did Haley go? She had the list of names. Did she go out? Hold on, let me rummage through her stuff. Ah, here we go. Okay. I can't read this. So I think what we have is, so we have the care management and coordination over here, and if I can find exactly who she wanted to assign that to. Here we go. Group 1. Okay, Group 1, that would be
Laurel Lee, Francie, and Tammy.
Laurel Lee, Francie, and Tammy. And are you guys are already over there? Great. Okay, so you're going to be Group 1. We would like you to be care management coordination. If you all take that area. Group 2 and 5 are being combined together. So that would, they will be back here. They're going to do because it's 2 that are being combined together, they're going to tackle governance and oversight as well as provider engagement. That is Caitlin, Allison, Rick, Paul, Carol, and Joe. Group 5.
Ludwig.
And okay, and then population health management will be Andrew Nelson, Don Fonder, Emery Shebazian. Did I get that right? Shebazian. And then Mike Vanderline. Oh, and Alan Fisher. Got it. Thank you.
And what group is that?
That would be population health management over here. And then for social determinants of health would be everybody else. Stacy Kessel, Kyle Davidson, Mike Dudas, and Terry Card. And what I would like for the folks from HCA that are here, if you could kind of divide into the different groups to actually participate, have somebody in each group to assist. And Haley and I will be walking around to kind of help out with that now. So if everybody can kind of go get in your groups. I do believe we have some pages like this for you to write on. The first thing we like you to do is identify who's going to be the writer and then the presenter. So what we're going to do is we're going to start with a 30 minutes time for the groups to kind of work together. We'll do a check-in at 30 minutes to see if you need a little bit more time or if you're kind of good with where you are. And then we're going to have each of the groups come out and just spend about 5 or 10 minutes presenting their thoughts along these areas. Does that work for everybody? I did. We just ran through it, and thank God Misty was here and helped me with that. All right. Thank you. Let's go ahead and start with 30 minutes.
Perfect. Thank you. Good.
I'm going to start with a group. And so I would have somebody in charge of writing and guess you'll look at is identify what revisions need to be made to what we, and this is a conversation around all of these areas, the financial alignment, brought up, government, I think there's a lot more in workforce and training that all the established right now. Discuss, talk about what long, right, yeah, I think right now we're still, when you say how they go from like 0 to 8. I think what we're trying to do is identify what are the capabilities of why they're important, how they reach the importance, what are the APM goals, what's not goals, how we can
Nobody's doing any less work or shifting over. It's all add. So it's a big thing for everyone. One, organizational buy-in. Yeah, that's how we're going to get it. And then, so that really directional work for yeah, please do.
If I may, right now,
I'm going to do a quick interruption. This is your local disembodied voice. I do want to make sure that as you're talking through these things, you really pay attention to that third bucket, which is ACH's role, because what we'd really like to do is make sure that when we come out of these discussions, we've got some specific guidance we can give to the ACHs. So thanks. Can we have maybe just a few minutes to wrap up and then come back together and report out? Sorry to interrupt the conversations, but I do want to have some time for report out. So if people can come back together, we'd like to hear from each of the groups.
All right, so let's bring everyone back to the center here. Thank you all for being, I kind of floated around the room. There were lots of great conversations. I think we're, while short on time, we do think it would be really great for each group to have somebody just spend a few minutes summarizing the key points along the 3 lines that we've discussed and laid out here. I would also just say, hopefully you wrote kind of the key takeaways or your notes on that larger piece of paper, because I think Missy is going to be collecting those. No, not this one, on this piece of paper. This is more important than the piece of paper on the wall.
We'll take anything.
Yeah, I was going to say, if you only have the thing on the wall, then we'll take that too. Okay, so why don't we go ahead and start with the governance and organization and provider engagement group. So Caitlin, is that going to be you? So let's just, because we only have a little bit of time, try to shoot for 3 minutes of presentation, and then to the extent we've got question and answers, trying to keep those short too. So go ahead.
So we kind of went off on every direction. We didn't necessarily bucket everything we talked about, but I think some of the revisions to key elements, starting with governance and organization, is trying to think about how we have from the get-go a state-supported message around why are we doing this, to what point and purpose is this happening, and that's actually going to help with provider engagement as well, so sort of stretches over everything. And this other recognition of provider organizations are struggling with financial sustainability in the short term as we make this transition, and then how to plan for long-term financial sustainability once the transition is quote-unquote complete, and being able to have some infrastructure elements built in right away to support that would be really important, both from a governance and organization standpoint and in provider engagement, so that people don't get burned out or think that it's not worth it going forward. Another piece, both in probably needing a recognition in the key elements, but also discussions for changes over time, is around revenue cycle and how in provider organizations we can adapt the revenue cycle process before actually implementing any sort of change, so that it's not something that's happening while we're implementing the change, because that's really going to disrupt both patient care and the abilities for provider organizations to remain whole or not take a huge hit and have to regain it or recoup it later. And then on, there's lots of stuff. There was lots of discussion. Some of the other things we talked about, especially around provider engagement, is not basing improvement necessarily on individual contracts with individual payers, and how do we help providers look at their whole population regardless and having it more payer blind to help them make improvement. Otherwise, if you're coming at them from each payer, it's going to be a challenge for them to want to still be a part of it and have to adapt per their agreement instead of per their population, which is really what they're there for, to help serve the client. And then the ACH's role. Some of what we discussed was whether or not ACHs have a role in building district incentives to get providers to align contracts across multiple payers so that we are all focusing on the same metrics, at least, and some of the same strategies and payment structures. Trying to set up district incentives to actually achieve our goals. I think a lot of the discussion was, in some ACHs we haven't totally, and actually probably all ACHs haven't had
contract provisions were not noted. We're talking a lot about data and a lot about what we're shooting for, but no discussion or pointing to where is that ultimate goal, and who's going to set that, and where are we going to find that, and how do we align that between the contracts and what we're asking of providers. Also, the secure data storage via clinical data repository. Secure data storage, absolutely. There's many ways to get to that. A clinical data repository is not the only way. So certifying in there that is an absolute key element, necessity, could be questioned. Changes over time. Overall, we need to build a system that meets providers' needs for technology and population health management for 2022 and forward. Things like a single care plan functionality need to be included, a system that aggregates clinical behavioral health, social determinant data, and then pushes it to appropriate users in real time, a system that's really nimble and can be moving this data around as providers need it, especially if we're asking providers to bear risk. Well, they need a lot of data to be able to assign risk and prepare for risk and all the other things that MCOs and risk-bearing entities do actuarially. We're going to have to provide these clinical providers some kind of mechanism for them to do that as well. And then with respect to the ACH's role with population health management, ACHs can certainly aggregate data and analyze data for a collective view. But probably most importantly, we thought that convening the regional partners to define first a vision of what is the population health strategy for the region, what are our resources that are already in place, what are the gaps, and then to define the requirements around both data and functionality. And if ACHs could do that regionally, and then we could bring that all together and get a view across all of the ACHs, we could really start to define what were individual regional needs versus what are more broad-based statewide generic needs. ACHs can also be a user of the data to align strategies and investments across the region, and then also provide TA, coaching, support, whether it be financial, workforce, other things will emerge as we roll up our sleeves and start the work to actually help providers transition to value-based payment. Excellent. Any thoughts from the room? All right. Last but not least, links to social determinants of health.
All right, well, this one was easy. I'll start with just saying that we really felt like because of the role of the ACHs that they should be the champions for ensuring that social determinants of health are brought into the care delivery system, and that they're doing that to really bring the regional back. So we looked at the elements already here and agreed with what was there and added one more. But in particular, in terms of the needs assessment, we talked about really need to be done at key level, closer to community level, and that would be a role that the ACHs could really play in terms of understanding the health data, community needs assessment, also bringing in any state level databases with the RGA mentioned that this bring in information to really understand what are the social needs of the particular region. And then also, needs assessment needs to be done at the individual level, and that really be the role of the care provider. In large part, we just have a relationship in order to get that information. But to do that well, we talked about the importance of workforce development and workforce implications to be able to ensure that they're getting accurate assessment of the needs of particular leaders. Knowing that care providers don't like to identify issues that they can't address, then the next one becomes of some importance. So knowledge of available services and education. We really thought it was the issue to know and share integration and closer commitment to health are part of as coordination and delivery protocol. And then again, bringing that regional lens to those protocols. And I think the one comes on that category with this services, this rural staffing program. The one area that we sort of called out as an additional key element, which I don't know if it's a key element for providers necessarily, but we need to really define what are the value-based payment incentives for veterans and health, and how can the money that's coming through the funds or other places support the system's capability in the different regions in order to effectively address social determinants of health, so that we can, in the end, create the value-based payment social determinants of health to the health care delivery. And then we said that this team here, the MVP action team, really needs to prioritize championing this last element to ensure that it is really effective for supporting.
Great, thank you. Any thoughts on that one? Comments? All right. We have a few minutes left. First of all, I'll just say I thought this was a really great conversation. I think Missy's going to collect all of the pieces of paper on the wall and also these things and share them with us. So what we'll do in terms of next steps, and I may be getting into what Mark's about to say, but is try to update this straw model that we put out there on the VBP capabilities based on the feedback we just got. And I think we would endeavor to share that kind of next version with you all to get any additional feedback. You know, one thing that I don't know if it was posed earlier, but to the extent there's kind of any additional capability areas that we didn't capture, I think that's something we would certainly welcome input on as well. Though there's quite a lot here already, so it might be daunting to add to the list. Mark, do you want to take it from here?
Thank you, and thanks everyone for really meaningful discussions. Just a few key takeaways that really kind of resonated for me in no particular order. One is that value-based payment, as we've defined it, really incorporates that group of approaches. It's not necessarily meaning that everyone has to move to capitation, so I think thinking of value-based payment really as that collection. I was also struck by the earlier comment about value-based care relative to value-based payment, and I think as we're talking with providers, one of the things that struck me is the importance of focusing our emphasis really on the importance of value-based care and the payment that goes along with and reinforces that. Also, that district is a 5-year journey, and we really are talking about delivery system reform and the incentive payments we can make to help that reform along. We're not, you know, sometimes it does feel like we're trying to boil the ocean, but I think thinking about this journey, and there were a lot of comments about sustainability, which I really appreciated. And then the comment I think Don made about the role of the ECHs and really kind of building up from that regional level, using the connections that the ECHs have with their communities to really be responsive to those community needs, but then in a cross-cutting way identifying those things that are in common so that as those rise to the state's attention, we can address things that may allow us to use resources effectively and efficiently across ACHs. So those, for me, again, those were just some of the more striking comments. So thanks again. In terms of action item next steps, Haley, I think covered that pretty well. We will be sending the provider survey out. We will be working with associations to get that spread around. We will be coming back to the ACHs and asking them for help as well to make sure that we've hit the right providers. It may not be the right term, but what the heck? That's we're still talking New York talk, right? So that's with respect to the next meeting, which is scheduled for September 7th, right, Missy? There are a couple things. One is hopefully we will have some feedback that we can share with you, some results, even preliminary results on the provider survey. We also will be taking a look at our VBP roadmap that some of you I think may have seen. Hopefully you have, it's on our website. We will be updating that for CMS, and what we'll try to do is send a copy of a revised draft of that VBP roadmap to you in advance of the September 7th meeting and ask for some discussion of that at that meeting. I think we owe our revision to CMS on October 1st, if I'm not mistaken. I think that's about it, unless anyone else has any closing remarks. Sorry, last time I did this, I think the past 2 meetings I've done this. Any comments about what you thought worked well for this meeting, what we could improve on? Any feedback of that kind that anyone wants to share at this point? Did the combination of kind of big group and small group activity, was that good? I see some nods around the table, so we'll try to incorporate that as best we can in future discussions, because I think it makes it a little bit easier for dialogue that way.
I think one more thing I'll just add is if you all think there's something else that should be added to the agenda for the next meeting, we want to just make a plug for suggestions from you all in terms of what the priorities for that discussion should be, in addition to starting to flesh out what we find from the survey and discussing the roadmap, and probably continuing this conversation too.
I actually do have one agenda item that might, and I don't know, this might be opening a can of worms. There's been a lot of discussion lately about how to do funds flow for ACHs and thinking the long term of sustaining it through value-based payment. And it might be helpful to have that conversation here. I don't think anybody wants to prescribe anything to any ACH, but it might be helpful just to provide a more statewide perspective on what that could mean and look like, because we are certainly struggling with it as MCOs going across the state, and there's a different understanding of what sustainability through VBP means in district, and attribution is a huge part of it. So
one of the things that's in development actually is some technical assistance for ACHs around funds flow, bringing in what other states are doing and what they've done, both as here's some thoughts and ideas and approaches, and here's what was actually done, and here's, I mean, it's kind of like a big list, right? I mean, not everything's going to work for everybody, but it's at least to present us. So maybe this might be a better first audience for it to bring in here and get some, kind of like these materials is bringing those learnings from New York and other places here to be vetted in this group to then be augmented and go out to the ACHs. I mean, there are ACHs here as well.
I would just add, because this conversation did come up actually at the King ACH yesterday, and there was honestly some confusion around this idea of how will value-based payment sustain the activities of the waiver going forward. And the MCOs were actually asked to potentially come to a future meeting and talk about value-based payment. I don't think we have clarity of answers around how just Medicaid managed care value-based payment will carry this all forward. I actually personally think it's bigger than that. So getting help around that from this group to guide that thinking would be helpful.
So I just want to add, I think that that's a key point. We talked about the funding part of being able to sustain the changes, and that no matter what we, how pretty we paint this picture, if we can't give the financial foundation on which it's going to rest and be sustained, this ain't gonna, I mean, we're gonna be, well, I'll just leave the analogy to your imagination.
So playing off all of these comments, Mark and I were just trading notes on maybe, let's ask it as a question. They're among the ACH leads here around the table. Do you think it's advisable to have maybe a conference call in August before the next meeting to weigh in on where you are with your respective ACHs on some of these critical issues around funds flow, around roles and responsibilities of data handling, partnerships, and so on? Because the tie between the ACHs, each of which, well, there's a huge variability in how they are progressing around the state, but there's a lot of accrued knowledge already, and we need to be in sync with that here, it seems. So would you be interested in a call?
I think a call would be helpful. I don't think a call at the beginning of, before we submit our certification phase 2 application, sure. I don't think a call would be a welcome request. But sometime before the next meeting would be useful, and maybe it would even be worthwhile to formulate a couple of, just 3 to 5 key questions and get them to the ACHs in advance of the call so that we have the opportunity to make sure that we've checked in with all the appropriate staff and stakeholders and work groups to get the right feedback for a call.
Thank you. Unless there are any other pressing items, we are at the end of our meeting timeline. So I just want to thank everybody once again for your participation